the first co-sponsored event from the Tobacco Research Interest Group and the Disparities Research and Methods Seminar Series. This is a really exciting opportunity for us to partner together to address, I think, really important issues across the country, but particularly in the catchment area for the Hollings Cancer Center. So for those of you who don't know, also just a couple of words about the Disparities Research and Methods Seminar Series. The series was started a couple of years ago when I joined MUSC to really bring together investigators who were interested in minority health and particularly health disparities with a particular focus on cancer outcomes. And so, as all of you within TRIG know, tobacco use and tobacco control is one of the really important risk behaviors that contributes to excess rates of morbidity and mortality among racial and ethnic minority groups and other individuals who are medically underserved. So I see Adam is back, and I'm just trying to use our time efficiently while we wait for the technical issues to get resolved. So Adam, welcome. I'll stop talking if you're ready to go. You're on mute.
Can everyone hear me?
We can. Yay.
We can.
Oh, goodness gracious. Next time, I'm just going to download WebEx to my computer. I was trying to join through browser. It's causing too many problems. All right. I'm going to try to share my screen now so you can get this presentation started.
I'm going to do an introduction as well. So let's have you start sharing your screen, and I'm going to start with the introduction. Thank you. Thank you, Shanita and Erica, for allowing us to do this co-sponsored presentation. I think Adam is shows exactly what we want to be, which is for cancer control, we have tobacco control and health disparities. And we have great researchers on both sides, and no one that truly does both together in the Venn diagram in that middle part. And Dr. Alexander checks all those boxes. I would like to say, so I met him through the Oklahoma group, Darla Kenzer and Michael Bucinel, who I'm very fond of and friendly with through SRNT. I was really impressed upon meeting him this past year. Dr. Alexander is an assistant professor at the University of Oklahoma Health Sciences Center. He is very accomplished as a young man. He already has 27 publications, which is quite impressive at the assistant level. His grants that he has under review have very interesting titles. I'm just going to read a few of his published work titles that I think are just that just kind of showcase how he is a new and emerging leader in the space of both tobacco control and health disparities. So he has a publication called Darker Skin Color is associated with a lower likelihood of smoking cessation among males, but not females. He has a publication entitled Soul Food, Reframing the African American Farming Crisis Using the Culture-Centered Approach. And Dr. Alexander has a K that is being scored, and I am hopeful and expect that it will be funded in the very near future. So we're pleased to have you. Please take it away, Dr. Alexander.
Thank you, Ben, for that very wonderful introduction, and I'm very excited to be here. I just want to be sure before I start, is my mic coming through, or do I sound very clear?
You're sounding great.
All right, excellent. Okay, so yes, as Ben said, my name is.
There's like a couple of gray boxes on the screen. Do other people see that? I just want to make sure that that's supposed to be there. Yeah.
Okay,
One.
thank you.
Okay.
One more still left on the screen.
Is it clear now?
Yep, now it's clear.
It's gone now.
All right, excellent. Okay. All right, so yes, my name is Adam Alexander, and I'm an assistant professor at the TSET Health Promotion Research Center. We were formerly known as the Oklahoma Tobacco Research Center, but we recently changed our name. And the title of my talk today is Understanding and Promoting Smoking Cessation Among African Americans. All right, before we begin, I just would like to acknowledge a few of my collaborators as well as a few disclosures. One, I declare I have no conflicts of interest. Also, the research I'll be talking about today has been supported by a variety of institutions, including the TSET Health Promotion Research Center, the Stevenson Cancer Center, and the Tobacco Settlement Endowment Trust. I also need to give special thanks to my mentor, Dr. Kinzer, as well as Dr. Busanel, as well as Team Kinzer and Team Busanel, who helped make the research I do possible. Before I start talking about the research today, I'm going to just give a brief overview because I think that will help orient you to the presentation. I've divided this talk into three sections: the introduction, the second section is called Understanding Smoking Cessation Among African Americans, and the final section is called Promoting Smoking Cessation Among African Americans. In the first section, I'm just going to give you an overview of my research program that involves African Americans. And the second section, I'm going to talk a lot about my research that kind of expands how we're thinking about smoking cessation for African Americans. And in the final section, I'm going to talk about my K01 project as it relates to my prior research. So without further ado, part one, the introduction. I refer to myself as a health disparities researcher with just a special interest in tobacco. And you can broadly classify my program into three different categories: theory, assessment, and intervention. When I think about theory, I'm thinking about how can I identify the barriers and facilitators to behavior change. And I typically use the precede proceed framework to do this. And why do I focus on health behavior? It's because we know that health behavior is one of the largest contributors to poor health outcomes in this country. It's responsible for about 40% of the annual premature deaths in the country. And I measure health behavior using a variety of methodologies, including quantitative and qualitative approaches. Quantitative approaches include ecological momentary assessment, as well as the use of passive monitors and sensors through the smartphone. And once I identify those barriers and facilitators, I use that to create, I think, interventions that are hopefully will be effective for minority populations, African Americans, and other vulnerable groups. And the way I design my intervention is usually using the precede proceed framework, which I think is a great way to identify all the factors that are responsible for engaging in health behavior change. And in using the precede proceed framework, they divide these factors into three distinct groups: predisposing factors, which are factors that make someone liable or inclined to engage in a particular behavior. In this case, we're talking about smoking today. We're also looking at enabling factors, which are factors that encourage people to engage in behavior change. And the last set of factors are reinforcing factors, which are factors that once a person engages in behavior change, how can we sustain that behavior down the road? And once you look at these three factors together, you get an idea of the appropriate theory you should select to help you design your intervention that will ultimately, hopefully, be effective for your particular population of interest. In this case, it's African Americans for me. And I have a very long research history, and it wasn't planned this way. It's just how it worked out. I have a very long history of research with African Americans, starting way back in 2014 when I was completing my master's degree. I published findings from my thesis that looked at religious beliefs among adolescent white and African Americans high school students, and trying to see whether or not religious beliefs protected adolescents from smoking cigarettes, and whether that effect was differentially associated among Black versus white adolescents. And I think those findings were very interesting, and they are out there published if you're interested in looking at those. Then in 2018, I finished my dissertation work, which was focused on looking at substance use disparities as well as mental health disparities after Hurricane Katrina. And this, if as you recall, Hurricane Katrina was a devastating hurricane that affected many residents who lived in New Orleans, most of whom were African American. And those findings still are very relevant, especially today during the current pandemic we're living in. And finally, I transitioned to my postdoc, which was recently ended as I received a promotion. But here, I really started building my research program that focused on identifying barriers or facilitators and risk factors that either promote or inhibit the smoking cessation process for African Americans. And more recently, I've been trying to translate that research into community here, because one of the downsides of our cancer center here is that they haven't made active connections with the African American community here. And so one of the opportunities I found as I've been here was that I can have a lot of ways to participate in the community and really promote smoking cessation among African Americans here, because this is definitely a problem among residents in our city. And so, as I said earlier, smoking is a very huge problem for African Americans. If you're looking at the smoking prevalence across the country, it's declining, and that's very positive. But there's still at least 10 to 15% of African Americans who are still smoking. And if you look at it compared to whites, it's slightly lower. But the problem is African Americans are way more likely to die from the leading causes of death that are related to smoking compared to whites. I'm talking about stroke, cancer, and heart disease. And if you look at secondhand smoke exposure, African Americans are way more likely compared to any other group in this country to be exposed to secondhand smoke, which actually further increases your risk from dying from these three leading causes of death. And to complicate this issue even further is that smoking cessation is a very severe problem for African Americans, despite them being very motivated to quit and actually making many quit attempts per year at the same level of whites. But if you look at the chart to your left, you see that at least for this age group, that the quit rates for African Americans between the ages of 25 and 44 are lower than for whites. And you may ask, well, what does this mean? Well, this is actually very important, because if we were to improve smoking cessation just to the level of whites, we can increase or decrease the race gap in mortality among blacks and whites by about 20%, which will go a long way towards increasing health equity in this country. And so that's what I'm going to attempt to do, and attempt to, talk to you about throughout this presentation. So now let's move into part two, which is going to get into my research, challenges and barriers to smoking cessation. And so when we think about smoking and smoking behavior, I think the first thing we need to talk about is socioeconomic inequality. Because the prevalence of smoking, it's much different for people living in poverty compared to those who are not living in poverty. And so when we look at race and poverty, what we find is that there's a higher percentage of African Americans who live in poverty compared to whites. And this is true in America and even in South Carolina. Actually, the poverty statistics for African Americans in South Carolina is a little bit higher than the actual national population. And when we look at that in the context of smoking, you find that people in poverty have lower quit rates than people who do not live in poverty. And the same is true for African Americans. And why is this important? Well, Dr. Nikki Nolan recently put out a study, a good study, that tried to address the cessation gap between African Americans and whites. She was looking at what factors could explain the gap between African Americans and whites. And what she found was there are actually three different measures that are indicative of someone's socioeconomic status that explains a large portion of that cessation gap. And those three factors are household income, home ownership rates, and living in neighborhoods with many problems and disadvantage. And so what's that saying? Well, African Americans on average have a lower household income than whites. They have lower home ownership rates, and they are more likely to live in neighborhoods with a lot of problems and disadvantage. And so when you take these three factors together, these factors explain a significant portion of the cessation gap between African Americans and whites. But we need to dig deeper into this because not only these are just objective indicators of someone's socioeconomic status. We also know that the internalized experience of living in poverty has important implications for someone's physical health as well as their mental health. But there's just an emerging area of research is looking at how the internalization of poverty or how people perceive themselves as to perceive themselves their socioeconomic standing, that may be also associated with health behavior, in this case, smoking. And so that's the first study I would like to talk about with you today. It's looking at the perceived socioeconomic status and its association or possible association with smoking after a quit attempt. And so in this study, I was just looking at a very simple direct association. I wanted to investigate whether lower perceived social status would be associated with smoking after a quit attempt. But in my research was something I particularly love doing. I love looking at potential mechanisms. So I wanted to explore what might be driving this association. And when you look at perceived social status, and what that research shows is that people who perceive themselves to be of lower socioeconomic status oftentimes experience anger. They experience a lot of anxiety and negative affect. They actually experience problems with sleep. And if you look at these components or these variables, these are also related to nicotine withdrawal. So I hypothesize that it's possible that people with lower socioeconomic, or people who perceive themselves to be of lower socioeconomic status, might also experience more intense levels of nicotine withdrawal after a quit attempt. And so we're going to see if that's true, looking at data that was taken from or collected from a clinical trial that was conducted back in Texas. And in this clinical trial, they were comparing the effect of providing contingency management or financial rewards for smoking cessation compared with conventional counseling as well as pharmacotherapy. And the reason why I'm using this sample because it's a primarily minority sample. More than 60% of the sample is Black and it's women. So this is a sample I'm particularly interested in. And the main outcome of this study is smoking status at 4 weeks, and is biochemically confirmed using carbon monoxide values. And the independent variable we're looking at here is subjective social status, which is measured using the MacArthur social status scale. And as I said earlier, our mediator is nicotine withdrawal, which is measured using the Wisconsin nicotine withdrawal scale. And that includes 7 components of nicotine withdrawal, which are too many to name for the sake of time, but they have things like sleep, negative affect, anger, anxiety, etc. Now, in these next slide, I'm going to go through the results and I'm going to walk you through it step by step. So in table 1, we're simply looking at the direct association between subjective social status and smoking after a quit attempt, without adjustment for a mediator and with adjustment for the mediator. And so in the first column, you see that, in the first column, you see that without adjustment for the mediator, subjective social status, higher subjective social status is associated with smoking abstinence after a quit attempt. But once you adjust for the mediator, the effect vanishes. Now, the next step you want to do is to establish evidence of an indirect effect, which is what table 2 will show you. And so table 2 is a bit more complicated, but I'm going to walk you through it step by step. And so when you look at the first column, this first column is showing you the effect of our independent variable on our mediator variable. And what this is simply showing you is that higher subjective social status is associated with lower nicotine withdrawal scores. And when you see the subscales for anger or anxiety, the same pattern is there as well. The reason why you don't see the 5 other components is because the evidence of mediation was not quite there. And so for the sake of simplicity, I'm choosing to show only the indirect effects that were significant for this talk. And when you look at the second column, our mediator on dependent variable, what you see here is that higher nicotine withdrawal is associated with lower odds of abstinence at week 4. And then in our second or third column, what we find is that this is our subjective social status and smoking abstinence relationship that I talked about in table 1. So I don't need to review that again. And then in our final column, this is actually going to establish whether or not there's any evidence of mediation or indirect effect. And what we do find that, yes, indeed, there is an indirect effect related to nicotine withdrawal. What we're finding here is that lower subjective social status is associated with higher nicotine withdrawal scores, and higher nicotine withdrawal is associated with smoking after a quit attempt. And if you take these, and if you look at the particular subscales here, it's particularly through anger and anxiety that's really driving that association. That's really what I wanted to look at. We know it's nicotine withdrawal, but what components of nicotine withdrawal are driving that association, that indirect association? It's just anger and anxiety. Two of the things I talked about before I analyzed, or before we start going through this data. And so in conclusion, what we can draw from this study is that lower subjective social status is associated with smoking after a quit attempt. And part of that effect seems to be explained by higher nicotine withdrawal scores, particularly anger and anxiety. And we can do something about this as researchers and professionals and public health professionals. We know there are known treatments out there to treat anger and anxiety during smoking cessation. And we may need to start including some of those components when we're dealing with people who identify as being socioeconomically disadvantaged. And this is particularly relevant for African Americans, who are much more likely to live in poverty compared with whites. It may be possible that they're going through their quit attempts with higher levels of anger and anxiety. And that theme is going to resonate throughout this presentation. You'll see that pop up again as we move on to this next study, which I think it allows a greater exploration of socioeconomic inequality, especially among African Americans. Because in this country, we tend to emphasize, when it comes to differences or socioeconomic inequalities, we always talk about, blacks versus whites, which is a very important topic to talk about. But socioeconomic inequalities also exist within races as well. And one of the unique ways we can study that, at least among African Americans, is by looking at skin color. And so skin color has an important history in the United States. It goes all the way back to slavery. While if I talk to you about the history of that, we can definitely be here the entire time just talking about that one topic. I can quickly go through some of the socioeconomic advantages that lighter skinned African Americans have compared with darker skinned African Americans. And the list is long. And so if you look at the literature, you'll find that compared to African Americans with darker skin color, African Americans with lighter skin color have higher household income, have higher self-efficacy scores, have higher self-esteem, educational attainment, have attained jobs with greater occupational prestige. And for women only, their lighter skinned women are more likely to marry male spouses with higher educational attainment. And that's not all. African Americans with lighter skin color experience lower levels of racism and discrimination and receive lighter prison sentences. So there appears to be a light skin advantage when it comes to socioeconomic prospects for African Americans in this country. Now, what I want to see is if there's also a light skin advantage for smoking behavior in this study, at least smoking cessation. And so the hypothesis is very simple. My hypothesis is that darker skin color would be associated with smoking after a quit attempt. But as I've said, I've always liked to dig deep into my associations. And so I need to know what are the potential mechanisms underlying this possible association. So I'm exploring factors such as discrimination and anger, hostility, as well as neuroticism. But I'm also looking at biological factors as well, because I think they may play a role here too. So I'm looking at things like nicotine metabolism. But that's not all. I think in this context, as I described earlier, that there was possible differential effects for skin color among men and women. I wanted to look at effect modification. And so I wanted to look at effect modifiers such as race and sex, because as I said, that skin color has a unique history among African Americans, but less so for whites. And so the data I'm actually using to look at this research question comes from a clinical trial that was conducted by Dr. Nikki Nolan. And this trial was called the Quit to Live trial. The primary findings have been published. And in this study, 449 blacks and whites received 26 weeks of varenicline And it wasn't a randomized clinical trial because they were more interested in understanding the cessation gap between African Americans and whites. Now, in this study, the main outcome, at least related for my study, is smoking status at weeks 4 and weeks 26. And this was biochemically confirmed using cotinine levels. And our independent variable was measured with skin color, which was measured using a spectrometer. And so this is more of an objective assessment of skin color. You can measure skin color subjectively using self-report questionnaires, but objective measurements, I think, are better in this case. And this device, what it does, it reflects, it shines light onto the skin. And the amount of light that's reflected off from the skin is used to compute a melanin score. And a higher scores on the melanin index indicates darker skin color, whereas lower scores indicate a lighter skin color. And we took these readings from 3 different areas of the body. And what I did was I combined them all and created an overall skin color score for each participant. And then I standardized those scores to reflect substantial deviations in skin color because I wanted to create distinct skin color groups instead of having just a continuous measure of skin color. Now, for our effect modifiers, as I mentioned earlier, we were using self-reported sex and race as our effect modifiers. And for our mediators, we are looking at discrimination, distrust, neuroticism, and nicotine and cotinine concentration to get a kind of a indicator of nicotine metabolism. And so I'm going to walk you through, that's a lot of figures and tables I'm going to be presenting in this slide. And so in this first table, we're looking at the bivariate association between skin color and smoking abstinence at week 4 and then at week 26. And if you just look at a bivariate association, not adjusting for any variables, what you find is that darker skin color is associated with lower odds of abstinence after a quit attempt at 4 weeks and 26 weeks. But however, once you start adjusting for your covariates such as race, you always have to control for race when you're looking at skin color because it's highly correlated with race. There doesn't seem to be any association between skin color and smoking abstinence at week 4 or week 26. And so not deterred, I then start looking at interactions. I think that's the most important thing to look at. And the first interaction you want to look at is one between race by skin color interaction. But what I found was that a race by skin color interaction was not significant, which was actually contrary to my initial hypothesis. But what I did find was a differential effect by sex. And these 2 figures will show that. But I'll show you the one at week 4 first. And so at week 4, I'm going to walk you through this figure. What you have on the y-axis is the probability of abstinence at week 4, and it goes from 0% to 70%. And then the blue line, or I should say the x-axis, you have standard deviation units. And if you remember, I standardized each person's skin color score. So what a 0 represents is a person with an average skin color in my sample, and a +1 or +2 indicates a person with darker skin color in my sample, or who has a skin color that's darker than the average person in the sample. And a -1 or a -2 represents an individual with a lighter skin color compared to the average person in the sample. And the blue line represents cessation probability for males, and the red line represents cessation probability for females. And what you find is that for light skin or lighter skin males, the probability of abstinence is very high, but as their skin color increases or their skin color darkens, their probability of abstinence declines significantly. And it's not true for women. For women, skin color doesn't seem to predict abstinence as well, and it maybe it slightly increases, or maybe the risk, or actually they increase their chances of quitting as their skin color increases. Now, if you look at the second figure, looking at abstinence at 26 weeks. What you see is the same effect, but the overall probability of abstinence has gone down because it's 26 weeks post-quit. But we still find a light skin advantage among males. And that's very, I think, fascinating. We're one of the first research team to document this association. But that's never enough for me. I always like to understand what is driving this association. So the next step, what I did was I looked at some correlations between numerous variables between for women and for men. And what you'll see right here is the results from a correlation matrix for males or men only. And I'll tell you why I did not show the female, well, the one for females in just a moment. And so when we're looking at the correlation matrix for males, what we find is that, and this is after controlling for race, so this is teasing out race. What we find is that darker skin color is associated with experiencing more discrimination. It's associated with having higher feelings of cynicism and distrust. So you're more likely to be distrustful of others. And it's also associated with higher levels of trait level neuroticism, which means you respond to very situations very emotionally, with a lot of anger, etc. And well, the reason why I'm not showing the correlation matrix for women or for females is because these three factors are not correlated with skin color for women. And so I'm like, wow, this is great. So the next step is to see whether these three factors would explain the association between skin color and smoking abstinence among men. And when I did this, what I found was these three variables do not explain the cessation or the increase in the risk of smoking after a quit attempt among men with darker skin. And so this study left me with more questions than actual answers. And so what we did find, and I can't conclude this, is that there does seem to be a light skin advantage for smoking cessation among, at least among men. And so what we find is that African Americans, or not African Americans, but men with lighter skin have a higher probability of being abstinent in the short term and in long term smoking cessation outcomes. For women, this doesn't seem to matter as much. There's a lot of unique risk factors that are at play when women go through their quit attempts. And so what can we conclude from this? Because as I told you earlier, we didn't observe a significant race by skin color interaction. However, the interaction we observe for males is actually still very relevant for African American men. And here's why. Because when you look at skin color, so skin color among whites, they tend to be around the mean. They don't vary a lot. Whereas when you look at skin color among African Americans, you can find African Americans have skin color just, it varies a lot, substantially a lot. So you will find a light skinned American who has a very light skin, very dark skin, or just maybe he's has brown skin. So they vary a lot around the mean. Whereas for whites, the values are clustered around the mean. And this is, I think, so the implication of these findings are very important for African American males, because I think they may require additional resources when they make their quit attempt, which can come from maybe having a higher and longer duration of NRT. And even though it was not demonstrated in our study, we may also need to start including components that in our interventions, especially for minorities and African Americans, that are treating things like distrust, discrimination, anger, and hostility. Because while I didn't demonstrate it in this study, this final study I'm going to talk about highlights the role that discrimination plays in the cessation process for minorities. And so why is discrimination so important? Because it's still a very important issue in our country. When you're looking at statistics at the national level, what you find is that 43% of adults report experiencing some form of discrimination, either from sometimes to even regularly. And if you break it down by race, almost 70% of African Americans are reporting experience some level of discrimination, compared to just around 30% of whites. And research has shown that experiencing discrimination is associated with engaging in poor health behaviors, including overeating, smoking, marijuana use, alcohol use, but essentially all the health behaviors that can lead to poor health outcomes down the road. But surprisingly, there's only been one study that's actually looked at discrimination in smoking cessation outcomes. That study was done by my mentor, Dr. Kinzer, and she was looking at it in a sample of Latino smokers. And what she found was that major discrimination was associated with poor smoking cessation outcomes for Latino smokers. Now, I wanted to replicate that finding for African Americans. Now, the problem with the data set we're going to be talking about, I wasn't able to look at major discrimination, but I could look at everyday discrimination, which is still an important factor to consider. But as I've said earlier and repeatedly throughout this presentation, I always want to understand what are the mechanisms that's driving that association. So in this study, I want to look at self-efficacy. Because when you experience discrimination, you're being a victim, you're being belittled. You feel as if you're less than a human when you experience discrimination and racism. And so I thought that self-efficacy would be the driving factor here that could explain why when discrimination might lead, be experiencing discrimination might lead to poor cessation outcomes. And so as I said, the direct effect relationship is essentially that higher discrimination will be associated with poor cessation outcomes. And the indirect effect I wanted to show for this study was that discrimination we associated with lower self-efficacy scores, and lower self-efficacy scores would increase the risk of smoking after a quit attempt or increase the odds. And the data we're using to demonstrate this association is coming from the smoking cessation trial I talked about in the very first study, which was a contingency management intervention for socioeconomically disadvantaged smokers. And in this study, the main outcome is smoking status from week 1 to week 4, and which was biochemically verified using carbon monoxide values. And our independent variable here is discrimination. We used the everyday discrimination scale, which is a very widely used scale that was developed by Williams, or David Williams. And for our mediator variable, we're using the perceived self-efficacy, self-efficacy slash confidence scale, which is actually not a general self-efficacy scale, but it's more of a situation-specific scale that's supposed to measure your ability to remain smoke-free in high-risk situations. And so before I talk about the analysis, I just want to break down the amount of discrimination that's being reported by minorities and African Americans compared with whites. And as you can see across every factor here, every question that's asking about discrimination, it's your minorities and African Americans were reporting way more discrimination during their quit attempt. And now this next slide is going to walk you through the results related to this study. And this is a structural equation model, and I actually simplified it to ease the interpretation for the talk. What we're going to be paying attention here is to if you look at the two circles, which are meant to represent latent variables, which are variables that our measures are intending to tap into. In this case, our everyday discrimination scale is tapping into perceived discrimination, and our self-efficacy slash confidence scale is tapping into self-efficacy. And so we look at the first relationship, the relationship between perceived discrimination and self-efficacy. What we find is that there's a negative association between perceived discrimination and self-efficacy, which is aligning with my hypothesis. Higher scores on higher discrimination is associated with lower self-efficacy scores. And when you look at the second relationship in the green box, what we find is that higher self-efficacy scores is associated with lower odds of smoking at each particular time point, except week 3, which was partly related to missing data. And so when you take those findings together, what we find is that perceived discrimination is indirectly associated with poor cessation outcomes through lower self-efficacy scores. And that's in perfect alignment with my prediction. And because I was using structural equation modeling, I was also able to show that there's actually no direct effect linking perceived discrimination to smoking cessation outcomes at any particular week. All of its effect occurs through self-efficacy. And so this is very important. What we're finding here is that discrimination does play a role in the cessation process, but it only seems to do that because it's affecting people's ability to think they are able to quit after making a quit attempt. Maybe it's because they're using smoking as a coping mechanism to deal with discrimination they're experiencing either before or during their quit attempt. And why is this so important? Well, as I said earlier, African Americans are perhaps one of the most the most frequent victims of discrimination in this country, and we need to be designing our smoking cessation interventions to treat discrimination for African American smokers, because this is something that is not quite looked at in the literature right now. We may treat some of the symptoms of or consequences of discrimination, such as negative affect, stress, and other things, but we're not directly tackling this issue of how can we change the way people respond to being discriminated against, or how can we make society more of a positive place where the actual prevalence of or the exposure to discrimination decreases across the board for everyone. And so this leads to my K01, which is the final part of this presentation. Promoting smoking cessation for African Americans. How can we design an intervention that will be relevant and efficacious for African Americans, smokers? And so the first thing I need to talk about is we need to tailor smoking cessation interventions for African Americans. And I'm not the first person to call for this. This has been talked about since the 90s. We know the literature says that African Americans are more engaged in smoking cessation interventions when the program materials have been designed to match their experience. And if you look at the table to the right, I'm listing a lot of different factors that are culturally relevant for African Americans that can be either used as components to support cessation or just considered as different risk factors that we need to acknowledge and treat in order to improve cessation outcomes among African Americans. And when you and this the research shows this as well, is when you culturally adapt interventions for African Americans, they're usually better able to address the risk factors as well as capitalize on some of the cultural strengths in the African American community, such as religiosity or family support. And why do you do this? Because I think that when you give African Americans the relevant tools and information, you actually increase their chances of being abstinent. And so once you encourage someone to engage in behavior change, how can we sustain it? And how can we do it in a way that's especially effective for African Americans? Well, I think I may have found the best way to do it, and that's by providing financial rewards for smoking cessation for African Americans. And so, this is called contingency management, which I've talked about previously throughout this presentation. And so, contingency management is simply just providing financial incentives for engaging in desired behavior or outcome. In this case, we're talking about smoking cessation. And if you look at a meta-analysis that was published by Half in 2015, he showed that providing incentives for behavior change among African Americans is better compared to other intervention modalities. What I'm saying is that African Americans respond more favorably to behavior change when they receive financial incentives compared to other intervention modalities, which is, I think, super cool and gives us a pathway to how we can possibly encourage behavior change among African Americans, and actually very relevant to the times we're living in, given that African Americans have been faced economic hardship during the COVID-19 pandemic. And I'm going to demonstrate this very clearly using the contingency management trial I've talked about numerous times throughout this study. So this study was called the Prevail study. And as I said earlier, they provided financial incentives to a group of socioeconomically disadvantaged smokers who were mostly African American and women. And what you find is that when you look at the gray line, you see that the people who receive financial incentives for smoking cessation had a higher quit rate compared with those who receive conventional therapy plus NRT. And this is present even at week 12. What we find is that the chances of abstinence is almost 4 times higher among those who received financial incentives compared to those who did not. But I wanted to know, why is that? I'm always trying to dig deeper into the data. And luckily, Dr. Kinzer, my mentor, included a question on the quit date, which asked people how important was it for them to earn financial incentives for smoking cessation. And I've used this to predict smoking abstinence at 12 weeks. And not just point prevalence abstinence, I'm talking about continuous abstinence. And what that says is that they were continuously abstinent throughout that entire trial. And when we look at this particular question and compare demographics, what we find is that it is your minorities and African Americans who report that it is extremely important for them to earn financial incentives for smoking cessation compared with whites. And what happens when someone says it's extremely important to earn financial incentives for smoking cessation? Well, just look at their quit rates. It's almost at 50% at week 12 if someone says that it's very important for them to earn financial incentives for smoking cessation. This shows you that this might be the intervention for minorities and African Americans. And so with the success of this intervention, my mentor decided to take this platform or take this intervention to mobile platforms because many socioeconomically disadvantaged smokers, including African Americans, don't show up to the clinic to participate in these type of interventions. So she thought of an amazing idea to bring it to participants' phones. And this grant has been reviewed by NIH, particularly NCI, and it received a very great score, a first percentile, and it's likely to be funded in 2021. And I'm an investigator on it, a co-investigator. And the reason why I'm talking about this study is because this is actually the basis or the foundation for my K01. But before we talk about that, I'm going to go back to my previous slide that I showed at the very beginning of the presentation to talk about how I think about my intervention. So throughout the presentation, I talked about many predisposing factors that might influence a person's decision to start smoking. And talking about African Americans, what we're looking at here is things like skin color, discrimination, SES, and other race-related stressors. And now what I think can help them engage in behavior change, or in this case, smoking cessation, is by tailoring our interventions for African Americans. And once we get them to engage in smoking cessation, how can we sustain that behavior for longer periods? And I think the way we do that is by providing financial rewards for smoking cessation or smoking abstinence. And so this rationale forms the foundation for my K01, which is I called Healthy Cells, because it's a cancer prevention app designed to treat smoking cessation, designed to promote smoking cessation among African Americans. And this is my K01 project, and it's a 5-year project that's being done with collaborators throughout the nation, as well as with our mHealth shared resource here at the University of Oklahoma Health Sciences Center. And this app is designed to promote smoking cessation using a variety of strategies. We're using contingency management. We're making sure the intervention is culturally informed, but we're also using components such as physical activity, which might further boost their cessation chances. And so it's a 5-year study, as I mentioned previously. And in year 1, we're going to be developing the app or developing the shell that we need. And in year 2 and year 3, I'm going to be interviewing African American smokers to get an idea of what variables I should be targeting for cultural relevance, because I want to include components, whether through text messages and videos, images that really capture the experience of being an African American, especially an African American smoker, but also offer strategies that might help them deal with some of the experience that are relevant for African Americans, such as being discriminated against. Like, one of the things that I've been wrestling with is how can we change or improve the way a person might respond to being discriminated against. And I think one of the avenues I want to go down is using mindfulness. I've been looking at research that shows that actually mindfulness buffers against the effect that discrimination has on negative affect, depression, and anxiety. And there's even some evidence showing that it might protect against engagement in some poor health behavior, such as alcohol use. So I'm thinking that if I provide supportive messages that, maybe help engaging breathing exercises or relaxation training, that this might help them alleviate some of the consequences of experiencing discrimination. And so that's what I'm going to be doing in year 2 and 3, designing materials that are going to give people the tools to be abstinent. And once they become abstinent, they're then financially rewarded for that abstinence, which I think is going to be very important. And in year 4 and year 5, I'm going to be evaluating this intervention in a small group or small single group design. And I'm going to be using those findings to support the development of a R01 at the end of year 4 going into year 5. So to summarize this presentation, we've talked about a lot, but you can quickly, I think I can crystallize it in two different categories. One is the problem. As I talked about, African Americans have poor cessation outcomes and have increased tobacco-related morbidity and mortality. And as I've talked about throughout this entire presentation, socioeconomic inequalities and discrimination play an important role in the cessation outcomes for African Americans. And so I think the solution to help address this issue is we need to start designing interventions that equip African Americans with the tools needed to promote abstinence. And what I'm doing at Oklahoma is I'm tailoring a contingency management interventions for African Americans because I believe it's going to help sustain motivation and self-efficacy to quit smoking. And the take-home message I think from this presentation needs to be that I think culturally adapting evidence-based interventions for African Americans and other minority populations is going to be the key to increasing health equity in the 21st century. So with that being said, I'd like to conclude my presentation. To thank you and for spending time with me to learn about my research, and I'll be very happy to take any questions you may have.
Thanks, Adam, for a great presentation. So we'd like to invite everyone now at this point to submit questions. And the way we'd like to do it is if you can use the chat button, the chat feature to submit your questions, just so that we can minimize the crosstalk, especially since I see many folks have their videos off. So Adam, one of the first questions that came in as you were talking was, what rationale was for controlling for race in your study that was looking at skin color, if that was the main exposure. And I guess maybe just a clarifying point will be for me is, did that study include both Blacks and whites? And if so, how and why is skin color relevant, particularly within a context that you described for whites?
Well, no, and so that's a lot of questions embedded within that. First, I did control for race because in that trial, they had a population of Blacks and whites. And so it was a balance between Blacks and whites in the samples. I think it was like 225 whites, 224 Blacks. And so I had to control for race because everyone was included in the analysis, because race and skin color are highly correlated, similar to how menthol use and race are highly correlated. But even race and skin color is more so. So you have to tease that apart in order to see is skin color having an added effect on smoking cessation outcomes, because it's already clear from the literature that race is associated with poor cessation outcomes. What I want to demonstrate is even on top of race, skin color is also having an impact on smoking cessation outcomes, which I think is what my study clearly does, because I'm teasing apart race from that argument. Because if I did a control for it, a person can say, well, that might be true, but you didn't control for race. So is it just a race effect? Well, what I can say is no, it's not a race effect. It's a skin color effect. And
so yes. Maybe, Adam, one of the things that we'd like you to do at this point is to stop sharing so we can see everyone. Maybe you can stop sharing your screen. I guess I'm missing the point, but I guess if you were interested particular, and maybe this might be my own bias coming out, but I mean, if you have white people and Black people, the issue about skin color, as I understood your talk, was that if you have darker skin color, particularly among African Americans, that's really might have negative consequences in terms of your social status and interactions. Mm-hmm. So I guess I still don't quite understand, if why whites were included in this particular analysis, if you were really interested in the effects of skin color among African Americans. Maybe that wasn't your question.
Well, and that's a great point. And when I say it, that's why I looked at a race by skin color interaction, because I thought skin color would be more relevant for African Americans than for whites. And that's very true. But I think skin color still plays a role among whites as well, because it's in the past, it's been associated with engaging in more blue collar work, because you're out there in the sun working really hard. And so your skin color is probably going to be darker compared to a white person who occupies a job that's in an office or in some other location with ventilation and less sunshine. And so it essentially becomes more of a class-related thing at that point. And as we know, class is related to smoking outcomes, including prevalence and cessation. And so I think while it's definitely more important among African Americans to exclude whites from that analysis, I think would not take advantage of the data I had available to me at the time to explore that particular association.
Okay. So there's another question. Just trying to keep up with the chat. Hold on just a second. So this question is about mental health disparities that exist for African Americans. And so the question is, do you anticipate including mental health disparities into your research program?
That's actually something I was doing before I got started with the smoking cessation research I'm doing now. My dissertation work, looking at the effect of Hurricane Katrina on mental health among African Americans and whites, documented that there were significant mental health disparities after Hurricane Katrina, particularly in the realm of depression and PTSD. What I found was that Blacks or African Americans who were exposed to the hurricane had almost 2 to 3 times greater odds of having probable PTSD and depression after Hurricane Katrina compared with whites. And those findings have been published. And I'm actually going to be continuing that work going into going into the new year when I start a cohort study here in Oklahoma that's going to be looking at the health or the mental health and physical health effects of COVID-19 and the unprecedented social unrest we just recently had or we're currently having in 2020. I think it's going to have a profound effect on African Americans' mental health and physical health going forward. And while I hear a lot of talk going on about COVID-19 and the impact that's having, I'm hearing very little about the health effects that, watching people being exposed to police victimization, seeing those non-peaceful protests as well as violent protests. I'm sure it's having an impact for African Americans. I'm going to investigate that in the new year. So I am actively involved in that research still.
Thank you. So another question is related to financial incentives. The next two are, and so I'm sure you're aware of all the work that's been done in behavioral economics and the questions that have been raised about the sustainability of financial incentives. So, I would also have this question, so I'm glad other people are asking it. One is, how sustainable is a financial incentive approach for smoking cessation and abstinence? And then the other, and one sustainable and I guess sort of the ability to scale up and implement those types of approaches on a larger context. But the other related point is, what happens when the incentives are removed? And so is there data to show that if you remove the incentive, people go back to smoking?
Yeah, there is actually some data that shows that. And so that's a common problem in contingency management. I completely recognize that point. And there have been strategies or possible solutions to address that issue. One is to apply to specific populations. I think one population has been successfully applied to is pregnant women. And as we know, there's a lot of health disparities there. And why would you use contingency management for pregnant women? It's because your goal is to protect the fetus, the developing fetus. And so you have an endpoint that you need until birth. And so if you can get them to quit smoking until birth, you can improve outcomes related to pregnancy. And then at that point, if they sadly return to smoking, you have still accomplished your mission, which is protecting the child. So contingency management can work in that context. But now when thinking about a traditional smoker who may not be pregnant, what can we do for them? Well, what my mentor does, she's currently investigating the utility of providing long-term incentives. And what I wanted to do a while back was look at ways that we can enhance other areas related to motivation. And so the idea when you give someone a financial incentive, you're actually you're actually promoting external motivation. They're motivated to quit smoking because they want to receive the incentive, which is fine because quitting smoking is positive experience and you want to reward that. But what I want to do is increase their internal motivation, which is quitting smoking because it's the right thing to do and is beneficial for you. So one of the things my K01 is doing is while they're receiving their incentives, I'm also targeting internal motivation. So I'm telling them, yes, you're quitting because you want to earn the reward, but you're spending more time with your family. You feel better. You're breathing better. You're able to do more. You have more money to spend on other things. And so I think by increasing internal motivation, by the time the financial incentives stop, if we can get internal motivation to a point where it's going to continue their efforts to be smoke free, I think we can successfully increase smoking cessation outcomes among my group, African Americans.
Thank you.
Mm-hmm.
Other questions? I think I've covered all the ones in the chat. And well, Ben has a question. How open are you to using medications?
Oh, for smoking cessation, we were talking about varenicline and other
Yeah.
with NRT.
Yes.
We currently are using Chantix in a study here at the Oklahoma Tobacco Research Center. My research and the studies are primarily using NRT, but I'm definitely open to looking at using other medications besides NRT.
Okay, great. All right. Well, Adam, we'd like to thank you for joining us today. Great presentation. We enjoyed, or at least I'll speak on behalf of the whole group. We enjoyed learning about your research. Thank you so much. Ben, did you have any closing remarks, or Tracy or Jen?
So a lovely presentation, Adam. I appreciate it. I would add to your CM comments that we've shown that it works for cancer patients too, and there's sustained quitting in cancer patients. So you can feel free to use that for future talks. That paper is almost published in NTR, and we have a larger study started. It's an R1.
Excellent.
So
glad to hear that.
Yeah, so great talk. I'm not sure if Tracy or Jen want to say anything more on behalf of TRIG.
I'll just say thank you, Adam, for a lovely presentation. This was a treat for us, and I appreciate you taking the time. It was a great talk, and I think it was of interest. You have elements of your research that are of interest to a lot of different lines of faculty here.
Thank you, Adam.
That.
Fantastic job.
Yeah, great stuff. Thank you.
Thanks. Bye, everyone.
Bye.
Bye-bye.
All right, thanks, Adam. Take care.